help. There we go. Please sign up for the website. You're going to miss out if you don't. There will be a calendar on there for future events, etc. And there's a way to put in suggestions for future ways, things like that. I'd like to introduce Cecilia Comerford, who is our new executive director. She's doing a dynamite job. This is her first soiree, so she's very nervous about this. So please give her an applause.
Hi everyone, thanks for coming out tonight. My name is Cecilia Comerford, and as Dr. Grosset said, I am new to the position, so I just wanted to thank you all for joining us. Let me know if you ever have any questions, concerns, really good ideas, or anything I can help with. I am always available. My cards are out there. Feel free to take one. Also, if you send something to the contact at bouldermagicciety.org, that also comes to me, so I'm happy to help there. So we have really great things on that table out there to go check out, including some naloxone to take with you and take home. So feel free to take some, and also make sure that you sign it for your CME credit. Thank you.
BCMS for sponsoring the CME tonight. They approved this for the educational portion, not the drinking portion. For the rules of engagement, CME is none of the material that's out of the lobby is allowed in this room because of the CME rules. But so please, on the way out, grab some naloxone, grab some of these little informers which have links and information about what we're going to be talking about tonight. Okay. Yeah, so let's come on up, and then we'll get started right away. It's 7:35. We'll try to keep people on time. Does anybody have any specific questions before we begin? Because once we start rolling with it, we've got 5 presenters for the evening. You have to talk fast. So this is a little bit of a background. Okay. I was at a meeting at Monarch High School a couple months ago, and the secretary of the audience sat down next to me and said, this is a serious topic. I said, why? He goes, well, my son just lost 2 kids on his lacrosse team to fentanyl poisoning. And I was like, oh my God. He goes, I think my son might have a problem too. And I said, oh my God. I said, what can the doctors in Boulder County do to help with this epidemic? And those that don't know, maybe Rachel's going to show this. There's been more deaths than the fentanyl poisonings and the opioid overdoses than go. So the national epidemic is going to become much more above the ground, common language. Right now, it's been a little taboo to talk about all this stuff, but a lot of times they blame physicians for being the first prescribers of this stuff. And so I really wanted the physicians in the community. I'm hoping Boulder County would be a model for the rest of the state for how the medical societies can influence the public health in their communities. Right? Boulder's, of course, a little unique bubble, but we can certainly set a precedent for how physicians can get involved with actually helping the public. And I have this image in my head, a motto saying from grammar school to grandparents. I want everybody to know about this because even a grandmother or grandfather might have kids that suddenly are not well. And so any kind of the whole goal is to prevent the death of some 14-year-olds. And that's what's happening. Okay, so not to be too dark here, let me pass it off to Rachel Hastings. Rachel Hastings is a police officer in Longmont. She actually was a medical assistant of mine, was going into the medical world, but thought that law enforcement was more fun. So, John, you want to come up here?
Come up there?
Well, let me make it first.
Hi, I'm Rachel Hastings. Like I said, I'm police officer with the city of Longmont. Now, I was police officer with Boulder for a couple years and then transferred over to Longmont, born and raised in Longmont. So I'm trying to get back to my community there. Yeah, but in the last 4 years of being a police officer, I have had firsthand knowledge, firsthand witness of this opiate crisis, the fentanyl crisis that we're seeing. In the sense of our overdoses are rapidly increasing. We have people dying left and right. We're seeing these pills coming in and out of houses and cars, and honestly, coming straight up from the border. So they're everywhere, right? And people who maybe have never taken drugs before are trying them. It's not necessarily the physicians who are always the ones that, hey, it's their fault for prescribing them. Yeah, people are just getting hooked on them, and we're seeing a bunch of overdoses. So I'm here to talk about that a little bit. It comes in 3 different forms. So typically we see there's the powder form, liquid form, and pill form. Okay, so that's just a pressed powder. Most of the time, it is the pill that we're seeing. Sometimes they'll take the powder, they'll mix it with some kind of like water staining solution, and they'll inject it through a needle into their arm, or wherever they can, really, and get high that way. The pills they're smoking, so they put it on a piece of foil. It's a tiny little pill. They light it with a lighter from the bottom. They have a little, we call it a tutor. It's a drug paraphernalia term. But they'll smoke it through that, and it's just an instant euphoria, right? So the addiction levels are very high. They're high for a very long time. They take anywhere from 10 to 15 pills a day, and they're smoking them. That's typically what I see is the pill form, the smoked form. It's rare that we see it injected, and then the powder is also rare. That I've seen some of the powder. I've taken it out of cars, I've taken it off people, but that's super dangerous stuff, as you probably know. You're all doctors in here, highly educated people, so that we're not necessarily allowed to test it, because if you open it, it's done, right? We're down on the ground immediately. So one of the times we don't see powder form, I have seen it a few times. But like I said, pills are typically what we're seeing. And I'll kind of, let's see, guys have some pictures on them, so we'll take a look at those. So these are some pills I've taken off the street. These are directly from my body cam or my cell phone that I take pictures of. So they're blue pills, white pills, and other forms. The next slide. These we call Skittles. They don't taste like the rainbow, but they do fill everyone in every form, right? There's no demographic to say, hey, this is the population, or this is affecting people the most, right? It's young, old, poor, rich, middle class, everybody, right? So we're not seeing that it's, the typical, hey, it's this poor part of the city is where most of our overdoses are happening because they're just down on their luck. While I get dispatched, I can tell you I get dispatched to every different place in the city of Longmont. The city of Longmont is great in the fact that it's very diverse. So we see people with $1 million homes and their kids are overdosing. We do see people who can barely afford to put food on the table and they're overdosing. So it's a wide variety of people. But they look like this. So if you ever see it, if you're an emergency physician or somebody who takes care of maybe somebody who is an addict, this is what they look like. Stand of a 30 and N on the other side. We call them N30s or blues. The street name is blues. So, but the Skittles, we even call the Skittles blues just because that's what everyone calls it on the street. But those are kind of the new thing that we're seeing. Yeah, this is just a bunch of random pills that we as officers have taken off the streets. These are some questions.
We're going to take questions at the end.
So I have a little bit of data. Fortunately, as police officers, we haven't really, or just as a nation in policing, we haven't really taken the time to collect the data until recently. I think it was just put in state legislation that we have to.
But that's because in the recent 400 years, it's exploded. So 2020, we don't really know. 2022, for overdoses, it's kind of more. I think I actually updated. I got more data. I think we have this is around 60, 64 as well. Narcan, that's from us as police officers. That's what we are giving. You guys all know that you guys all just got outside. That's what we carry. I carry 2 of them every day. One for me, somebody else, just in case. And then deaths, like I said, we don't really have data. 2022, we did have 3 deaths after giving Narcan. This is just one more time. This is one more PD. I know Boulder significant increase. Really, within the last couple of weeks, they had 6 overdoses in 36 hours. I'm sure everyone saw that news post. We had 4. So it's just, and that's just us getting dispatched, right? We don't see all of the overdoses. A lot of people are carrying Narcan. A lot of our users do get Narcan from like Walgreens or something. So it is out there. It's just expensive. This is the map. This is the city of Longmont. So not highlighted bubbles. Those are just kind of where we're seeing a lot of the overdoses. It's all over the map. There's no specific place to say, hey, this is the richest, this is the poor, this is middle class. It's all over. Let's go to the next one. And then the state is actually, there's a program, not everyone's participating, but this is kind of hard to see. Boulder is here, big bubble here. It's very yellow. A lot of overdoses. Okay. That's Longmont, really, Denver is participating. Denver would be also. And they're seeing a lot of this. And then these are some of the mountain towns. People coming from out of town. There's drug dealers that are giving it to them. We're seeing that a lot. Hopefully this gets better, but these are kind of our hotspots. As you can see, we're in Longmont are pretty high up there. It's Boulder County. So it's a real crisis that we're seeing out there. And then demographics, like I talked about, like some of our data from Longmont, ages 14 to 29, we had 18 overdoses within the last 2 or 3 years. This is what I could gather from 2 or 3 years that we actually collect the data from. 30 to 39 group, 34 overdoses, so it is affecting the kind of our middle age generation. 49. Population, not really seen it as much. I think just because maybe they have maybe a little more excuse about it. I don't know, maybe that's the kind of population that is having more surgeries, not to, stereotype that, but so we're not seeing as many there. And then we have 5 ODs from an unknown demographic population, but a lot of it is our younger generation. I did have recently, it was last week or 2 weeks ago, we had a 14-year-old, we got called, 14-year-old and a 17-year-old. 17-year-old saying, hey, my girlfriend tried cocaine. He's not responsive, he's unconscious, not breathing. The breath's like, oh shoot, that's an overdose, right? And we know just from being in a job line that cocaine is not just cocaine anymore. Cocaine is laced with fentanyl. And they had no idea. So they were sold fentanyl. And then they stored it or whatever they did. And he was unconscious, not breathing. We got there after administered Narcan, through the nose immediately, and came back and had to go to the hospital. I think she was there for a few days because I took a huge toll on her. He's 17. He then started overdosing in front of us. So then he collapsed. They gave him Narcan as well. I don't know if he was transferred to the hospital, but yeah. So it's happening all over, all age groups. If anyone has taken college, and for them, right? an experiment, but we don't know what is really in drugs anymore because those pills that I showed you, those are being sold as oxycodone. They're not fentanyl. It's mostly fentanyl. And it's unknown amounts of fentanyl in each pill and not regulated by any means. So sometimes we'll see an influx of pills, which means an influx of overdoses, because the drug dealers are like, hey, let's just put it together. We'll give it to the general public, see what happens. People die. Then must be good stuff. So that's kind of their philosophy. We deal with the repercussions of it. So the socioeconomic classes, obviously, I said, doesn't really affect one class more than the other. Our transient population, I didn't really touch on. We're seeing a lot of it with our transient population, but that transient also means homeless. They are kind of our dealers, if you want to say. So the dealers are giving it to the transients where they're seeing the drugs. That's happening a lot. And then I've actually seen them give it to kids. So kids will be walking down the street, they know these kids. And they'll give it to kids. So they're 14, 15 years old. And then race ethnicity, primarily majority, it's a large majority, male overdoses is what we're seeing. I don't know why. If you don't know why, I don't really answer that, but I have my thoughts too. But yeah, a lot of males who are overdosing, way less females. I mean, honestly, I would say I see a mixture, like 50-50 in males versus females. But I also deal with the transient population as well, and a lot of them, it's kind of equal male to female. Yeah, and then Caucasian, Hispanic, Black, and Asian, as you can see, the most we are using are Caucasian. And I would say that's probably pretty accurate. Although we kind of have it here, probably south or southeast. Right? We don't have the same cracks as everybody else. So that's most of it. And then naloxone, you guys all got today. But how can you help? We can be educating the public about this stuff. It is expensive, so we got to figure out how to get that price down. That's our price. That's what we pay. I don't know what the general public pays. Not for one box, it costs $70. Yeah, that's it. Have questions?
We take the questions that are answered. Write down your questions. We'll run around and get them. We'll start to do a Q&A if we have time. So Mike Dougherty is the Boulder County DA. He's agreed to come and give his 2 cents about this.
Well, good evening, and I'm really excited to be here because when I first sat down with Cliff and Celia and realized that in the multi-pronged response we had in Boulder County to this crisis, medical professionals have not been an active part of it. So I really want to thank Cliff for helping to bring us all together tonight. I will say, to pick up where Rachel left off, as the district attorney, we now treat every drug-related death as a homicide. And on any homicide, we're notified by law enforcement, and we will respond to the scene. Make sure that the investigation is going the way it should. And here in Boulder County, I get a text or call, I would say at least once every week, saying OD, M30, age 62, age 31, age 19, whatever it is, looks like possible addict. And then we roll out resources to try to do everything we can to figure out if the death was caused by another individual who should be held responsible. But I want to just put in context, I'm getting calls in text once every 7 days. That's how often it's happening. So having you engaged in this effort, I think, is absolutely key, especially given what you do and the expertise you offer. So previously in Boulder County, we used to see heroin and opioids were the biggest problems for many years. And then transitioned to synthetic opioids such as fentanyl. We see them time and time again. And one thing I talk to college kids about when I'm at the university is when I was your age, someone might offer me a drink and I could or could not take it. But I never had the thought that if I took a sip, I would die. But that's the reality for college kids now. Fentanyl is being found in all these different substances, cocaine, marijuana, heroin, everything is being laced with fentanyl. And people who are taking fentanyl without knowing And I don't refer to those as overdoses, I refer to those as poisoning. If someone takes a substance, they think it's a painkiller, for example. We had a case where this happened, a young woman, and she never wakes up. We have other cases where people are addicted to fentanyl because it's more powerful and cheaper than other drugs that they've taken. So it is a real pressing crisis for all of us. There are some positive signs, and I think the multi-pronged response here in Boulder County is the right one. So I want to leave you with a couple takeaways as I go through a couple comments. But first, I wanted to talk about the criminal justice system. I was asked to talk about how these cases are handled and how they come into us. They either come in as deaths or drug distribution cases. The state of Colorado has chosen to treat drug addiction as a public health crisis. And if you agree with that approach, right, you agree with that approach, then we should really focus on the dealers. Because they're preying off that crisis. They're preying off addiction and they're profiting off addiction. So we do a lot with regards to dealers. So right now, with this very moment, we're up on a wiretap with the county law enforcement, and we are interceding in different deals that are taking place. We also go after the people who caused the death. So we've had a number of cases, including that death of the young woman, where we're able to trace the drugs back to the person who was introducing fentanyl-laced substances, knowing there was fentanyl in the painkiller pill, not telling the person he was selling it to. So we prosecuted that case. He was convicted of trial and convicted of manslaughter. One of the good news, pieces of good news that I'll share with you is last year, as Rachel indicated, there was legislation that we fought for and supported and got passed here in Colorado to change a number of things, one of which is a significant to you. Like for us in the criminal justice system, it was having a penalty for our distribution of fentanyl resulting in death. Previously, that manslaughter case I referenced, the sentencing range was probation to 6 years. Which, in my opinion, if you poison someone and they die as a result, probation of 6 years is far too low. So we fought to get the law changed. If that case happened today, or when that case happens today, the maximum is a range of 12 to 32 years. And the penalties went up for all the fentanyl-related deaths and fentanyl distribution. That bill became a lightning rod because of the possession piece, but really the parts in there that matter around fentanyl distribution resulting in death and it being pushed into our communities. The piece that should be of interest to you, as you consider what to tell patients, is the first time in Colorado's history that a tremendous amount of money was put into drug treatment, medication-assisted treatment, drug counseling. We have not had that before in the state of Colorado. We lag in the bottom 10 nationwide in substance abuse treatment being that worst member. We have things set up in the jail and things set up in the courthouse to treat people struggling with addiction, but they shouldn't have to hit the doors of the jail or the courthouse to get help. And you see that in your patients, I'm sure, over and over and over again. So now, for the first time, Colorado is investing money in people at a level that we should. So there are more resources available in Boulder County than there were years ago. The one thing I would suggest is connecting with harm reduction or treatment centers, particularly those that your patients can afford, and finding out in advance where they are. Because you have to develop trust with your patients, of course, you're treating your patients. And from our work in our drug diversion program, they're not always looking to be talked to about fentanyl, looking to get whatever treatment they need for an issue if they're coming to you, but being able to refer them to a place they can afford is really key. So I can push out some of that information to Cliff with Celia and have that go out to all of you. But I think that's a particularly important piece. The funding that came from that was House Bill 1326 last year. A really important piece of legislation. The other piece on fentanyl that I want to really stress is law enforcement in Boulder County and the District Attorney's Office has developed a protocol that's now being used in many places in the state. We have a Boulder County Drug Task Force. We developed this protocol to treat every drug-related death as a possible homicide. And it takes a tremendous amount of work and resources. The reason for that is often when someone dies with drug-related death, they're left alone. And the only way we find out where they got the drugs from is if we can get into the phones or the computer devices. So the resources that go into that used to be almost overwhelming. But now with the funding we have from that bill, we have resources available to us in Boulder to break into the devices and find out where they got the drugs from. So we're able to do a lot more on the criminal justice side now than we were just 3 years ago. And I think that's a really important step. We have a drug diversion program in the DA's office where if someone's struggling with addiction, we connect them with treatment in the community. We're looking to get them help so they don't end up dying or returning to the justice. So if you have patients who are struggling with addiction, we're not looking to send people who are struggling with addiction to jail. That doesn't happen on their first arrest. Doesn't happen anywhere in Colorado. When you look at the data of possession, which was defelonized in 2019, people are not going to jail or prison for possession. It's really focused on distribution, and that's a key part of it. The other thing to be aware of that I want to give you as a takeaway is Colorado has what's referred to as the Good Samaritan law, where individuals can call for help if someone has an overdose and not be criminally prosecuted. They have immunity as a matter of law. It's not up to the district attorneys. As a matter of law, they have immunity. So with Cliff and I are spending time together and we're using drugs, the type is going in the wrong direction, by the way. If you go in, so Cliff and I together using drugs, the key goes down. Under the law, I have immunity if I call 911 and remain on scene and cooperate with children or fellow officers and with medical professionals to show up. So even distributing that information to your patients who you think are struggling with drug addiction would be really helpful. I did the ride along. I did ride along to speech to the performance in Boulder County. I did a ride along with CUPD on a Saturday night around 6 p.m. to 4 a.m. By the way, I have young kids. This was like a do not send your kids to college video. The whole night was full of young people, college students, who had either overdosed or drank so much that they're friends with. CU, from my perspective, just based on everything I know from CU, but also from that night, they've done a great job messaging this to the student body. The time and time again, we show up at the scene, someone's on the floor, and the student says, "I have immunity, right?" You're charging, can you? I don't think you can. I think that's the first thing coming out of that. To me, it's a success, actually. They're not running away, they're helping their friends. Law enforcement is getting there much faster, and it's because that Good Samaritan law is in place. So I applaud CU for getting just the community, and something we could all be doing to the folks that we interact with, think might be struggling with drug addiction. And just having handouts in your offices about the Good Samaritan law, which was just extended. So by fentanyl, low-level fentanyl distribution as well. So I know my time is coming up. I really want to stress in Boulder County, we're fortunate, it's a multi-pronged response. So we have a group that meets once a month that includes Boulder County public health providers, treatment providers, doctors, law enforcement liaisons. So we don't all line up on the same issue every time. So we have healthy disagreements at times too. But our goal is to always collaborate, share resources. Boulder County tends to be regarded as a leader in addressing these issues. If you coming to these meetings and being a part of this effort really fills me with hope and optimism for the work we do together going forward. Happy to take questions at the end, but now I'm going to introduce Rob Phillip. Rob is with the University of Colorado's Center for Prescription Addiction Prevention. I'll turn it over to Rob. Thanks so much, Jordy and officers, and for having us here tonight. My name is Rob Alec. I run a prescription abuse prevention center at CU and CHUS. So CU Boulder grad, son of CU, brother from CU. So I definitely feel like I've lived a long time and experience in Boulder. But I appreciate also from a very medical family. Fathers and anesthesiologists, brothers who are cardiologists in primary care. The black sheep of the family is a dentist, of course, here in the Boulder County. So very medical family. And so I've seen all of this. Also, people in the family with use disorders, people in the family with chronic pain. Dad was an anesthesiologist, also had 4 laminectomies, 43 surgeries beyond that, and lived the last half of his life in severe chronic pain from his back. And could see the effects of what does that do to a person, how do you try to manage chronic pain from that kind of serious set of injuries that he had. So I've seen this from all different kinds of angles, and all that. I've spent my training is in clinical pharmacology and toxicology. So I'm the pharmacology concept kind of person. I've seen it there, practiced for a while, and then got sort of dragged into by a friend. Hey, come work on this policy stuff with opioids. And for the last 15 or 18 years, I've been doing policy work at the state level, running our statewide sort of opioid task force, which we call the Colorado Consortium for Prescription Abuse Prevention. But Governor Hickenlooper at the time asked us to get together and try to implement some statewide things and coordinate work at the state level. So we do a lot of policy work, everything from prevention to early intervention, harm reduction, treatment, recovery support, all across the full continuum of care. trying to build more systems that do the things you heard about, get people into treatment, diverted from law enforcement wherever possible, and get people into treatment. But from the medical side, what can you do? That's what I was asked. What can you do? And the things that we work on that I think are most relevant for practicing physicians. And I think really, you have to view yourself as someone who is more directly involved in talking to people who have these issues than you think. That this isn't the patient in front of me, so this doesn't apply. So I'm really not a frontline soldier in this work. And that couldn't be more further from the truth. If you write opioids, it's about being really responsible with them and spending just a few seconds with people, telling them how serious this is. These drugs work, they have their place. I'm not anti-opioid. I'm anti sort of cavalierly use opioid. And if you are trying to give, I'm going to give you just a few of these. They're very potent. 1 in 6 people I give them to, and I can't tell if you're 1 in 6, is going to develop long-term disordered use. When you tell people that in pause just for 2 or 3 seconds, and that sets in, you're like, whoa, wait a minute. Because people always say, had I known that my odds were 1 in 6, I might not have taken these so cavalierly myself, the patient. I might have said, well, maybe I'll just take 1 or 2 over the next day. I'll try to get over the active program. If I had only known. But we know that. We just don't have point of care testing that's fast enough and cheap enough to do it for people. We can't wait for you to get the answer. You have to prescribe something now. But there's 1 in 6, 1 in 7 are going to develop long-term disordered use. You can just tell people this is what you've got to know. These are powerful, useful drugs in certain circumstances, but there are risks, and you have to be very cautious with them. If you do use them, store them safely and dispose of them when you're done. Do not leave them around, lock them up, or keep them not the last place you want to keep them is the medicine cabinet. That's where your kids go and your friends go and your house goes and everybody goes. It's the medicine cabinet. Still, more than half of people that end up diagnosed with use disorder and seek treatment started with the leftovers in someone else's medicine cabinet. That's still true. It's not even the ones you gave. I gave you 20 tablets. It's the 16 that were left that somebody else took. You're contributing to this medicine cabinet full of opioids. It is really the starting point for most people. Most people do not start by calling somebody or getting on TikTok and doing that. Most people still look in the medicine cabinet. It's a lot easier. It's right there. We still need to work on that. And that's docs and say, hey, you do this, these are potentially dangerous. Be very careful, don't take them any longer than you have to. I don't want you to be one of the 1 in 6. Store them safely, or kids will get into them. They know where they are. The kids are smarter than you think. They're smarter than all of us. New technology, like I can barely make the microphone work. Kids will find stuff immediately. Dispose of them when you're done. Safe disposal. Don't think I'm going to save this for later. It's the leftovers that kill people. It's not the 4 tablets they took. Unless the 1 in 6 got activated. It's just, we always say our first PA campaign for our consortium was take meds seriously. And that's the whole point. Like, this is serious. Opioids are powerful. They have their place. But treat them that way. And just give the gravitas to patients that that's what we're dealing with. I'm not unwilling to treat your pain. I'm here to treat your pain. I am telling you that these are not without risk. These are not without danger. You need to treat them that way. This is serious stuff. And you treat them with the due caution and precaution that you have. Then lastly, I would tell you, become a harm reductionist in your practice. You don't think you need to do this? Yes, you do. Because people are using it. Your patients are using it. They're not maybe coming to you, but they are using it. There are people with behavioral health disorders, alcohol use disorder, cannabis use disorder, opioid use disorder. They're in your practices now. You may be diagnosing them in treatment for that. And I would encourage you to do that. Even if you're not, they are there. Underlying, you're doing more to try to screen if you possibly can, do effort and early kinds of light kinds of things. You don't want to become an addiction specialist. Hey, I can screen, I can keep my eyes open for this. And I can talk to people and meet them where they're at and say, if you are using, do some things to reduce harm. Have lots of them, never use alone. And you do things to reduce your harm. Stay alive is an action. And there are treatment resources if and when you want them. You don't have to be crazy. You don't have to turn into, look, you can do a whole thing like I said, about 30 seconds. And I know that's a lot of time. You're going to, in any business, 30 seconds is still time, money, and that's a lot of time. You can do those things. And those are the ones that I think are the most practical things. Any doc in any setting, seriously, dentistry, emergency medicine, like that dude over there, is one of the best emergency physicians I ever met. And, you know, stays like on a daily. But it's like, you know, you can do these things in any setting. My brother, the dentist, can do it. And he's all about can do this in dentistry. And he's found a couple of people in it, because he can see that now. He can see things like, hey, I see the dental chair in Kennedy. What did you do for the person? I just referred someone to addiction treatment last week. Boom, you know, just save a life. That's the kind of attitude that's not me necessarily, but it is. All of us to recognize our neighbors, recognize our kids, recognize our friends. What's going on with them? That isn't right. It isn't right. How can I help? That's why we're all doing this. That's why we got into medicine. I did even my unsold version of it, but my whole family got into this the same rate. We can all do our part. So that's my job, and I will now hand over to the person I just set up with that. Or I'm going to go first. I'm sorry, I'll let John go. Over to He's going to introduce yourself, just FYI, so induction badass.
Thank you. First and foremost, thank you guys so much for having me here. My name is Raquel Garcia, and first and foremost, I'm a woman in long-term recovery. What that means for me is I've not had or misused a prescription in over 13 years. I start with that everywhere I go, and I get to go in a lot of cool places. And the reason I start with that is because nothing I do, have, or say nothing I've experienced comes until that started, right? And so I like to share that when I first get on a stage. You know, I'm from Colorado, born and raised. And here, so my husband actually native to Colorado. I grew up in the southeast of Boulder area, and childhood, my father actually is a black man who was segregated until he was 18 years old, and grew up in South Texas. My mother is a foreigner from the south of France. Growing up was very different for me. I ate great, I promise you. Anything from poulet à la crème to collard greens and black eyed peas. My childhood was good. And so I was about 9 years old. And when I was 9 years old, I was sexually assaulted by a woman in my neighborhood. And at the time, I had a really good community. I had a small little town called, or a little street called Mercer Drive. And I think always, even way back then, I always wanted to like help everybody. I was going to be the neighborhood person. I had dance parties in my front yard. I had all the girls, we did pop and preach. I used to gather them with plastic bags. We'd go around the neighborhood and we were called the litter bugs. But that's our name, and we're us. And we walked around the neighborhood and we'd sing songs. Litter bugs never litter. Litter bugs never litter. But what can we do to help you? To stop littering up our world. And I loved it. To drive until the assault happened. And after the assault happened, unfortunately. And so I never really knew what to do with that. My father and mother didn't really talk about those things, and I kept that to myself. I went on and built my life, went to high school. I graduated from Eagle Crest High School. Back then, I was a varsity soccer player, a student council president. Not valedictorian. I was about to say that would have been a total totally not valedictorian. Pretty popular in my youth. And then tragedy struck me again. When I was 16 years old, I was at home and I watched the news, only to find out that I just murdered a Chuck E. Cheese in the world. I can't even tell you. At 16 years old back then, unfortunately, seems to be quite the way the world today. Back then, that just didn't happen. I drove 100 miles an hour down Iowa. When I got there, it was the reporter who tried to take a picture. Actually, to this day, if you go look at the gentleman who, and I can't talk about it, but the guy who did the murder, if you look at it, you can actually see 16-year-old blonde woman in his documentary about himself. The documentary that day, you'll see me. And after that, unfortunately, tragedy hit me 3 times. So my friends were murdered. I was sexually assaulted by a boy at a party. I was drinking. And I lost my soccer career. I was hit in the knee and got my ACL torn. And everything I had went away. And so I did what I said do. I picked up a drink at 16 years old and continued that until I was 32. I had 3 kids. My husband of 26 years is in the back. That's the bird. And we got married when we were 19 years old. We have 4 children. At 32 years old, about 31, right after Jake was born, I found this very, with a little bit of pain, my back hurts. My back went out. And so I had to have back surgery. And I got back surgery, and then a cerebral fluid leak and a TR malformation, all combined into one giant catastrophe. Now myself addicted to Opana. And I mean lots of Opana and lots of Norco. And one thing they didn't do was tell me the thing that you said. Like, hey, by the way, if you take these for a little bit too long, you might not be able to get off them. I have no idea. I have no idea. So I had a combination of Jack Daniels and Opana and Norco. Because you're running from Aurora, Colorado, all the way to Palmer Lake, Colorado, population 2,200. When I moved to the Palmer Lake, there were 3 people of color, me, Sylvia, and Darnell. Small town, you know, it's all I need. And I moved there and I tried to be sober, but I didn't last. I picked up a drink. I actually tried some AA in Aurora, ran there, but I found the liquor store when I got to Palmer Lake and I found myself. I didn't let go. And here in Denver also as well. Let that go. But I never let the go. I couldn't quite get off that. Every time I tried, I itched and I ached, but I could feel when it itched and it went away. One night, my girlfriend Donna came over. Her and I were talking on the phone. Sort of made 2 left to drive up mountain to talk with. I said, come on, girl. You come. She's like, come over. I said, but you should. I have something for you. So when she came over, because I'm friends, and in the community of the drug culture, when you're active, to actually have me share my drugs, my substances with you, they're really nice. Because mostly I'm not going to that. You can be very selfish and you're substance use. So, but she was my best friend. And I laid a little sliver for her, and I'd already taken it for her. When she took that Opana, she laid her head back. I said, I want to go to sleep. You're passing out. She said, no, girl, I'm not going to sleep. I said, you should. And she did it again. Oh my gosh. Oh my God. He's not breathing. He's like, call 911. Didn't even think about whether or not I was going to get hurt, but I'll tell you that right then. Did not. I'm still glad it exists though to this day. I attempted to resuscitate at the time one of the other paramedics who got there stayed with me on. Nothing she can do. We found her dead that night. She left behind her 2 children and forever changed my life. I'd like to say that after that, I got sober, but I didn't. I actually tried to join her. So they left me. In the psych facility, while I was there, they were feeding me Norco because I can't stop it at this point. So they're feeding me in one window. And the nurse looked at me and said, I know how to get you to stop craving alcohol. I was like, okay, this is my thing. So she tells me about Fentanyl. And she injects me with Fentanyl. And I walk down the hallway with lunch, and I just remember blasting. And I go into the most insane mental psychosis, physical withdrawal of my life. Nobody tells me what's happening. And literally, I'm losing my mind. And it was me out of the psych facility to more and more people help me get on it. Nobody would help me get off. Nobody would tell me what was going on. Someone died in October. I don't remember Thanksgiving that year. When they let me out of the hospital, I thought I'd stop. But I went to her funeral that night, and I saw her kids walk in the door. And I'd like to say that I wouldn't drink, and I promised those doctors when I left that second story I wouldn't. I don't have any other tools. They sent me out on my own. So I went to the funeral, and that night, I took a drink. And I stayed intoxicated. October, November, December. And in January, I just knew something really bad was gonna happen. And I just had a double mastectomy 4 days prior. And I was in Aurora, and I poured myself on her doorstep. And I said, I gotta go to help. I'm gonna die, my kids are gonna die, and I was already dead. And so I was. And I didn't have a drink, and this was the prescription since that day. And today, my recovery is dedicated to that. Nobody would even know about her or know her story if I didn't get to walk her from the planet pulling it. Back in brain surgery and those pills, and I think about like what I could tell you guys, because you put someone on it, help them come off with it. Tell them that, you know, if it's hard, I'll help you. We can do this in a really slow fashion. And if you can't get them someone who can. That's what I didn't have. I didn't have any support, no knowledge about what's happening to me. Thinking about the substance. If someone would have told me, like you said, 1 in 6 or 7, maybe I wouldn't have been so willy-nilly about it. Warn me about the possible poisoning of my children. My son, 2 years old, accidentally had an overdose. I didn't even know where he put in his mouth. My sister used to keep pills in those film cases, little weapons, and he ate them. And he just wouldn't wake up. I had no idea. This is 13 years ago before I wanted to drown. They're raising children. But nobody said anything. And I love the way that you said poisoning versus like an intention behind it. So to help remove the stigma for me is to make it about the pill and not me. Yes, maybe I do have a genetic predisposition. The reality is, if all of you take those pills for a certain amount of time, your body will crave it. If you take them, your body will want it. Try to take them off of them yourself. That's why I feel my professionals struggle, because they're trying to mentally get themselves off of them when their body wants them. Do you need Naloxone? Tell me how to use it. I put OB rescue on every phone I can. Where people are intimidated and I'm like, great, this is great app. You can stick it on your phone. You don't know how to do it. It will walk you all the way through it. Because most people are fearful enough to empower them. And like I said, you put me on it to help me. But that's, you know, right now, peers are taking over the state. We work in hospitals, we're working in emergency rooms. Right now, we have in our Colorado Springs, if I have a patient or a client that's in need, I can take a client to the morning hospital and there's a peer recovery coach in there. And I can make sure that they're dignity and respect while they're in that space. So make sure that they're cared for, you know, because they get the right resources when they need them. You know, one of my own is when we were Dr. York. I don't know why he called me and said, hey, we're having some special thing about the amount of opiates we were asking for. Can I ask you some questions? Don't be afraid to ask questions. I love that doctor. He didn't know anything. He said, how can you feel about more? So why do you think that is? I said, you know, maybe we don't need them. Maybe we need alternatives. You know, back then they just put me on pills and all kinds of things. Have more space to your spine and things like that. Does it have to be any way that you can choose to take a pill? Here, and here's what's important to me. The reality is I didn't go to doctors because I didn't think you cared. I didn't go to doctors because I thought you would shame me for it. I thought it would be about my morality, not just me having an issue. And I didn't really actually ever think to go to a doctor for a substance use disorder. But if I knew that was a place and you don't have to start, but you have someone you can connect them to, like, hey, I don't know what I'm doing, but my specialty, but maybe this peer can help. He's gonna do it. He's gonna do it. It's powerful. Peers are powerful. We've seen that work happen all over the place in Colorado. And now, as a peer recovery coach, 13 years, I put myself through college and have a degree in addiction counselor, but I didn't actually use. I do. I actually advise the state, the Behavioral Health Advisory Council, and the co-chair of the advisory council. I also advise the advisor on the state of Opioid Awareness Council. And I get to teach. Facilitate courses, and I run my own coaching practice. I have 26 coaches who are in recovery, active recovery, who take care of 275 people across the state. We have 6,000 people we help every 6 months online, actually probably most like 8,000 online. So the other thing is to look at your clients, your patients with potential. Right? I am that patient. You know that where I am when I'm struggling, look at the potential of what we become, the right supports and the right people around. The potential for us in Finland. We're brilliant. We're just struggling. We need the right people around us. And I can't imagine. I have great doctors now. My doctor team's amazing. You know, if I had one doctor, it's like the world. So I wanted to be important. But everybody's around me. Nobody wanted to ask me. So doctor after doctor after doctor. And I just was in chronic pain. I have a burnt man on fire disorder. One for the university, they're so great to me. And they make sure that I don't get opiates. Alternatives to help me. Just remember cares of purpose and remember the potential of your patient. And that you want to be the help us. You just want to know that you want to, and that you won't shame us for it. That's it.
So I'm downstairs. I'm an addiction and emergency medicine physician, and I do like for work across the state and across the country, mostly trying to teach clinicians that this is something that we can have a tremendous impact on. So I usually like to put up these thoughts just by getting the temperature of the room. And I'm going to ask you guys to raise your hands. First, if you're a physician, I'm great. You guys are great. You're going to talk to. Okay. Is you guys all prescribe opioids? Most of us do. It's only a few hands. How many of you prescribe naloxone or give naloxone? Great. So I just want to again take because what I saw is when most of us most of us prescribe opiates, yes. But then most of us do not prescribe the things that we can use to treat addiction or to prevent overdose. So what that tells to me is we have a and very few off that. Right? And I say that not to be judgy, because also I have my own recovery story. I was a chronic overprescriber of opioids, and I was an abuser. So I didn't abuse opioids. When I say abuser, I mean I actually conducted mental violence across prescribable use disorders because I thought they were bad people. Just like story like kind of I'm half Vietnamese. My family from tremendous trauma and war. A lot of people who end up with an addiction because they're trying to escape that trauma, that reality. That's the true pathway into addiction. It's not just euphoria. It's actually trying to escape the trauma, really from trauma. Right? But in medical school, growing up, I was taught that my uncle had drank too much. My cousin had a problem with. These were all the bad people in my family. I wasn't taught that they had a medical disease. I was taught that they were bad people. So throughout residency, I was taught, hey, there's lots of opioids, lots of bad things for pain. I know many of you thought something similar. But then when it came to people who struggled with it, I was taught to basically be flippant about them and to treat them like trash. And I used to people who have tremendous trauma. You say, what the hell are you doing? What's wrong with you? Now, if you really go back, you right? So what happens when you verbally assault and traumatize someone who's already in trauma? Do you think you're going to help them? You think that was the speech they needed? And then 180? No, I made people worse. I'm in town again over the first 5, 6 years of my career. I offered them nothing except bullshit advice, judgment, malice. And I was an abuser of those patients who came looking to me for help. This may resonate with some of you. Maybe it doesn't. Maybe you're much kinder than I was. Remember, I was told the ER doc, right? But for those of you who have not treated those patients with the dignity and the deference that they deserve, that the child deserves, I'll remind you that there's a Goethe quote that really sums us up beautifully. Be a person as they are and they'll get worse. Be a person as they should be and they'll become what they should be. And that light that we can provide to all our patients. And I did not see many hands raised to say, hey, I'm a physician, but I don't prescribe naloxone, which again can save a life. Or I don't prescribe buprenorphine, or I don't treat addiction. You guys are the key. You guys are the offering. You guys are who we need. Not saying this is medicine that I can and want to learn. And to be honest, it's medicine that's transformative. Transformative to kids' lives. There's no greater mortality benefit in medicine than putting patients on medication for opioids. Number needed to treat, that's 2. Right? To prevent potential overdose after complication. This is some of the best medicine we've had for so long, but we've limited behind a wall of stigma, of judgment, of saying that this is not our responsibility. How many of you see patients with diabetes? How many of you treat diabetes? How many of you say, okay, you're diabetic, all you need to go to an endocrinologist? Well, I'm very soft. Same thing though, with let's say, hypertension and renals. We've all taught that these very common disorders, and addiction is a very common disorder. We've all taken up that aegis and said, this is part of medicine. We treat diseases, people get better. That's not for diabetes, that's not for hypertension. And guess what? We can do that for addiction. Not every person with use disorder is to see me in my addiction clinic. In fact, most of it can be treated very well with a primary care doctor that they know, respect, and have their best. You have to make a difference. You really impact your patients in a much more deep way than we know. And I hope that many of you, if you're not using these tools, the Naloxone, buprenorphine, etc., you're aspiring to explore them and aspire to use them. They're easy. That's what I'll tell you. An idiot ER doctor like me become more certified in addiction medicine because it's easy. Right? This is stuff that you can all learn. And just like diabetes, if we only had endocrinologists treating diabetes, you'd have lots of people dying from diabetes. It has to be something that a whole medical system treats. And then finally, and this is another common kind of thing that I talk about with many clinicians, especially. You get to 107,000 dead Americans every single year from a medical disease. You don't treat it, right? And in medicine, I think what we've expected from ourselves is to create a predictable miracle. Someone who comes into us with type 1 diabetes, who 50 years ago would have been a death sentence. If someone dies with type 1 diabetes after presentation, all of us would be outraged. Because that's a treatable disease. We could give that person insulin, it could save their life. In medicine, all of you, whether you treat cancer, treat heart disease, treat hypertension, you create predictable miracles. When people could have died, where the lives can be forever changed. But because of your interventions, your hands, you save lives. You prolong lives, you improve lives. Right? When it comes to addiction, we don't treat that disease. Your hands have shown that. We don't treat that disease. That's not us. It must be special somewhere. Maybe somewhere we have it. We create a lot of predictable things. And we don't treat the treatable disease. Predictable treatments. And these treatments are available. You can all prescribe them. Many of you now have them. But make sure any patient who struggles with any type of use disorder, maybe that's an alcohol use disorder, has naloxone, you give that to them with a message of hope, recovery, and care. And if you're not using buprenorphine, why not? There's no exclusion. There's nothing stopping you from using one of the safest, most transformative medicines that we have to treat people with addiction. So again, I'm gonna be a little more aspirational for you. I want you there. I want you as part of this program. Because until doctors like you join, we're gonna continue to lose 107,000 or more Americans a year because of the medical system that doesn't treat medical needs. Thank you.
You didn't, that was excellent. Questions, please write them down. We'll run around and sort them and gather them. One of the reasons I wanted to have this night was, as Dr. Skinner was saying, we all, for those who are still practicing, we all have a responsibility for public health. And, we're on the front line of communication, whether or not we're dealing with people who have addictions. And by the way, talk about stigma, they got rid of the word addict. It's no longer my vocabulary. I say people with addictions. And you all have addictions. I bet you somebody, has bought an alcohol every night. Kids have an addiction to social media, gambling. Describe yourself. So the whole stigma of addicts is out the window. But the idea that physicians, I think the Boulder County Medical Society as a collective group could potentiate what the public health is doing, what law enforcement's doing, what the addiction counselors and on the back end of this addiction epidemic is doing. What I found when we were trying to organize this evening is that there's so many people in this river, but there's so many little rivulets that are part of it. They're not really coordinated. Everyone's in their own lane. You're trying to change policy, and you're trying to help kids in front line and you're afraid to, open up a bag because you might die. You're trying to help people that have lifelong problems and dealing with things beyond addiction, just trauma and everything else. As physicians, we have the privilege of actually educating our patients, in my mind, like I said, from grammar school to grandparents. Everybody should know about this epidemic, and they didn't even mention the word fentanyl tonight. I don't know if you heard about gray death. There's somebody in this audience that told me about gray death. Does anybody know what gray death is? Raise your hand. So gray death is a compound of heroin, fentanyl, and carfentanil. How many people know what carfentanil is? Raise your hand. So carfentanil is an elephant tranquilizer, right? Fentanyl is 50 to 100 times stronger than morphine. Carfentanil is 10,000 times stronger than morphine. And I found a website where you actually show you how to make it. It's from the 1950s, and there's omofentanil, there's carfentanil, there's several of these synthetic, highly potent synthetics, and the brainiacs from wherever they're coming from, south of the border, etc., buying these, $1 worth of 1,000 sugar pills, and they're dropping this stuff on each of the pill. They're not measuring out like organic chemistry professors. They're just dropping it on, and supposedly carfentanil, you got 2 minutes before you actually stop breathing, just like your friend. And that, to me, that's the poisoning, that's the Russian roulette, because everybody needs to know that the stuff that's in the street, you have no idea what, marijuana, cocaine, meth, you have no idea if it's laced with this, just call it cyanide. It can just kill you. And that shocked me. I couldn't believe that these people, drug dealers would sell a product that would kill their customer. But you can spend $100 and you can spend $100 and make $1 million. It's a good return on investment. I understand their logic for doing this, but to make a fast buck. But I think the physicians have an opportunity to actually make a huge difference in the public awareness, which is what we're trying to do here tonight. And really, part of it is the prevention side through the awareness program. The other side is the treatment side, and the state has gotten $700 million from the Purdue.
731.
731. That's over. That's over And I came from 18 years.
But we won't be at this a little longer. I'm gonna let that look.
Yeah. So one of the questions I had is one, how can we get naloxone available with no financial friction, no financial barriers to the people that want it? Every time if I write a Vicodin prescription, Vicodin is helpful in situations. And don't get me wrong, I mean, there's an orthopedic surgeon I was talking to you earlier tonight that I need that because post-operative pain is, you can't just give them a motion. It doesn't work. And so, but the idea that 1 out of 6 might end up going down a road, which
My husband just had surgery, and when he got it last time, they made sure when they gave it to him, he had naloxone. It was like came with it. That's
and it should be either we say, listen, you need to get this along with it, or the pharmacist hands it out when they give out the prescription that's filled by our prescriptions. But it works in the just dispensaries. It's going to be over the counter. Who knows when, how long it's going to take, etc. But that, to me, that's the biggest friction point. But the idea is to educate everybody that naloxone saves lives, as Dr. Stater was saying, and that's, to me, that's the take-home message. And the fact that even that 85-year-old grandmother, if she gets a prescription for something that their grandkids can get into that could end up killing them, I mean, that's our responsibility right there. And also just hearing the stories about their mother who heard their teenage son in their room gurgling, and she didn't want to go into a teenage son's room, and they found him dead in the morning. You know, it's just being aware that this stuff is floating through the streets. I think gray death has not yet come into town, has it? It has. And then there's stuff called Trank, which is, large animal tranquilizer. That's being put into the system as well. So even the Narcan won't reverse it because they're sedated. It's not an opiate, it's a sedative. I mean, the wisdom of these dealers is beyond me, but, it doesn't fit with logic. But anyway, I'd like to hear, how the money would be spent. First and foremost, what the plan is for that $700+ million for the state.
Well, actually, there's some regional councils that have set up, like I help oversee Region 12, which is like the Dougherty County region. There's, I don't know how many, I'm gonna be off because I just started, which one of the regions? 19, okay. Regions, and first was like about a bunch of infrastructure money was invested first in regions, so that it goes down for every region in Colorado, it's on hold. The next $731 million obviously has to stretch over the next 18 years. I'm telling you, we should make sure that lasts longer than 18 years because they're going to be at this a little longer than that, just to be honest. And so it depends on grant funding now. You can look. Also, there's opportunities for doctors, not just those of us on the recovery side. There's some opportunities for you to apply for grants. The next grant will be going out. Maybe in the next 30 days. And if you go to the Colorado abatement the website, it'll give you video. It'll show you every dollar. You're going to look at every dollar is going out across the state. It's easy to map out and see where the money came from.
Can you comment on Fentanyl?
The tramadol, most people think of the state opioid. That's always how it's marketed to many. I think that many of us in the addiction space, which I often do, it is just an opioid. Consider it just another opioid. Because the rates of addiction from tramadol and transition are just equal to any other opioid. Oxycodone is the worst when it comes to likability. Oxycodone is a medication that I ask. I think, this is very commonly used, but it's the most likable, has some higher street value. Hydrocodone is safer. Those have some benefits in terms of respiratory depression, treatment of chiropractic, etc. But if you're using it with the thought that I can just because it's not addictive, that is valid. So I'm happy to talk a lot more about tramadol and other big alternative opioids, etc. I'm also going to use opioid right now as you market when it comes to treatment of chronic pain, when it comes to treatment of opioids. It's a little less important. It's really more chronic pain and just because support.
Can you comment on test kits.
Oh, yeah, that was us.
The closest to medicines that they have test kits in there.
I'm happy to do that too. The fentanyl test strips are really a wonderful harm reduction tool, especially for patients who do not use opioids as their primary treatment. So people who use cocaine, people, you're a college student, who use a pill because they think it's ecstasy, and they're going to use it as a if they can test that pill and see if one of them has fentanyl in it, it changes their decision to use or not. Right? If people use methamphetamine, same thing. Because now you're empowering that patient to know what they might be ingesting, and that usually has the health benefits because people typically avoid using drugs if they didn't let fentanyl in. Or they might use drugs more safely. Meaning, hey, it might be contaminated, but maybe I'll make sure it's not as Narcan, or I'll make sure that I'm injecting it because I'm watching me. Right? So in those such populations, yes, we should be using that fentanyl test kits.
I think there were several questions in resources about what does an overdose look like, and how do you use Narcan, etc. We're going to put that on the website as well. BCMS website, there will be links to speak with you.
Yeah, that little phone out there, there's a little keyboard phone. I suggest you get OP Rescue on your phone.
It walks people through it. What does an overdose look like? How do I respond to one? What do I do in the middle of the crisis? Like, I don't remember what someone told me I don't remember the steps they told me. Just walk you through it. How do I give an Narcan? Walk you through it. Afterwards, you can report what happened. We've collected 3,600 reversal reports in the country in the last 3 years with this app about what's happening with people. And this isn't what law enforcement is doing, which we need to know. We need to know what EMS is doing. We already know. We know what happens in hospitals. We know what the theater does. We don't know what happens with lay people. What's happening? That's just another swim lane of data that we need to know from patients and their friends. What's happening? We're collecting a lot of interesting data. Like 49.5% of the time, nobody calls 911 because they're afraid. So the cops don't show. They can't. Nobody got dispatched. These happen half the time. We're seeing half the iceberg with all the stuff that the EMS and cops will do. The other stuff we don't see. But we're learning about that in this app. This app also has a treatment locator and an naloxone locator. If I want to get more naloxone, where do I find it? If I want treatment resources, where do I find it? Click on the treatment locator and find the map, and you can find treatment in the area. So it's a really good free tool. Just give that to people. It's a resource for them to be able to have something on their phone and not have to think about it, because we want them to have naloxone and OP Rescue together, and then people are equipped to be able to respond.
Also, for all of you, the welcome back and please make sure everyone's controlled out. If you scan the QR code, it takes you the videos that we use oftentimes in patients in the ER that basically recognize and respond to overdose. As in the naloxone project, which is a nonprofit, we're going to avoid COVID naloxone, which tries to get medical providers to be able to do naloxone to help with patients. We actually have a program now where we have 3,000 doses of naloxone that we're earmarked for primary care or rural practices. So after we'll be sending an email, hopefully up to Boulder County, and free naloxone to give to at-risk patients. We should be taking applications and selling free naloxone to give to patients who are high risk in the next
Especially mamas. That's my preach.
You have to destroy the pill. Just like the chocolate phenomenon is over there. You have to, someone has to decide to destroy a pill. That's just one of the pills to see what you someone got. They're not perfect, but they are a significant step in just brushing away.
Mike, can you talk a little bit about how does the data get out to the public? The stage or the naloxone. Why is that not published like they used to have the COVID deaths? Why is that not public information? It doesn't have to identify who, but how many. And and the politics behind that, or is it simply just a logistical thing?
So it is tracked now much better than it was years ago, and it's publicly available at the end of each year. So I can send you Boulder County data for the last couple of years, and then the whole state. And then importantly, we now have more responsive data tool for law enforcement and healthcare providers, treatment providers, called ODMAP. So on my desktop, I can click on ODMAP and see where we have known overdoses. And then we have clusters that prompts the law enforcement through notification. So that's part of what we had the 5 affected overdoses here in the city of Boulder a week or 2 ago. That's part of what drove immediate media announcement. So we see 2 or 3 people go down as overdoses or poisoning on campus, for example, that will not ODMAP information being shared. People in this space, in the treatment recovery space and law enforcement space, have access to ODMAP when we push that out right away. That information is publicly available data and overall numbers at the end of every year, and I can send you links to that for any knowledge class all you after this.
You mentioned that disposing of the medications properly, what's the best infusing of patients, what they definitely do the 16 tablets.
So tell people do not save them under any circumstance. Like leaving the load gun on the counter. Don't save them. You think you're saving it for next time? Get more next time. Because that's dangerous to have those in the house. People will find them and start them. So dispose of them. Safe use, safe storage, safe disposal. And then dispose of them when you're done. Mail back pouches, deactivation pouches. If you look for the takemedsback.org, it lists out all kinds of disposal sites where you can take them to drop boxes in pharmacies or in the public health departments or law enforcement departments. Some of them have in law enforcement. And look at partnering with all kinds of people, the sheriff's department and Summit County Sheriff or Summit County Public Health, like which do you feel like, or wherever you want, and dispose of those medications. But stress them. Get rid of these when you're done with them, whatever you don't use. If you need them next time, I can give you more. Don't stockpile these because that's a dangerous vector. It's still the most common vector in for first exposure. It's really important to do the safe disposal there.
There's one question about testing the 1 or 6. Possibly.
And we have the pharmacogenetic testing and PGX testing available. If you can wait 2.5 weeks and you got $1,700, you can do it. So it's not ready for point of care. It's not there yet. It's complex testing to do, and you do have to go live and send it off. And there's only a couple of labs that are running the PGX for that right now. So it's not. I mean, again, with the turnaround times, you need this decision right now. You can wait. So it's unknowable in the clinical setting. Can't find out who the 1 in 6 or 1 in 7 are. But they're there underneath.
But they know, like, if I have a family, I would have known that was me. Like, if you would have told me that my dad, because of racialized trauma, had an alcohol use disorder, if you'd have told me that because of my family, I would have looked around my family and went, whoa, my odds probably good that this could be me. Because, and so I think that even if you empower me, then it's my decision. And then it's like, to me, look at my family, okay, well, we still are children. I see this in recovery. We feel very young to them. The chances of having this disorder are higher than most. I can't say, I don't know what my children are going to do. I would say, if you can't get out, nowhere to go. I don't want to, they're very much, they don't drink. My 2-year-old is like, they have different experiences. But I don't save them from the honest truth. Because I want them to be aware that the chances of taking substances, and once they pick up, they may have a struggle putting down. I want them to be with them. Look at their family on both sides. Look at this side of the family from someone sitting here with mine. So I want them to be aware.
You don't need a lot of tests. This is a human test. You just have to talk to people, and you have to know about the mind doesn't see what the mind doesn't know. So what are the risk factors? The first is if there's use disorders in the family. Also, that patient has use disorder. If they're a smoker and they have difficulty smoking, and that might be drug addiction. If they struggle with anxiety, depression, mental health disorder, those are common things. People start self-medicating their anxiety with opioids. It's very, very powerful anxiolytic, right? So those are 2 of the big ones. The other things that people who catastrophize pain oftentimes will have higher rates of use disorders or opioid dependency. So for that person who, they talk about their pain and always the worst thing and the pain they did, so, their descriptions of the pain are like, they went athletically for 10 minutes without singing. It was like 5,000 something or less. There's all people go to catastrophize, they have a high risk. If you talk with your patients, and I talk with patients when I prescribe them opioids, and if they have bigger risks, but they have a need for opioids, I say, the risk to develop a problem. What would you like to do with that? They say, I don't want an opioid, I want a short prescription, I'll work with them. But if they say, no, I'm okay, I just want to know, then I'll prescribe it to them, and say, you just need to watch this longer. We need to keep our eyes open in case you start using these. And you say, well, I'm using these now because it just makes me feel better for my depression or etc. This is a human test. No one should be getting for $1,700 lab test.
Coming to a close here, so I'm going to ask the panel that go down the line. The physician's question is we have very little time. What would be that 10 seconds, if I wrote a prescription for Vicodin for somebody with intent, understanding what you've just presented tonight, what would be my 10 or 15 seconds, one-liner that would motivate my patient to want to respect what I'm prescribing, but also to follow up and do some research, get the app or go learn more about the lifestyle, etc. One of the intents of this evening was I thought if we talk our patients into believing that the opioids are dangerous medicines, they're not just painkillers, they're dangerous, they might be asking us less for the opioid refills, right? And so there might be a positive feedback and all this. But I don't know who wants to go first. Like this, the 10 second, here's if I can, and what's the feeling of blood? It's a 10 second, it's not a 10 minutes, it's a 10 seconds.
I'm actually gonna, and I hope you don't mind, respectfully push back on this narrative that we just went at. And one of my favorite quotes is the Vinci quote, which is once you have a why, you can adore anything. And if you are practicing positions that way, right? There's another favorite quote that I like, which is if you want something done, do it for this person. Okay? If you want to treat substance use disorders and pay well, you're going to make the tackling those skills. And what I'm going to tell you here is that you can apply those skills at all. Okay? So I work in an ER where I see 20 to 30 patients in an 8-hour period. Some of them very high acuity, some of them very low acuity. Our practice amazing pain and addiction medicine. Because I've decided that it was on me, it was part of my responsibility as a physician who cares for my community and learn the skills to do that at home. So my challenge to you, if there's a chance of change, I'm not going to do this to you. Let's see how many of you are going to start grabbing them on game. How many of you are going to start thinking about the strategy to my sense of change in the company. As what else I said, I was going to do something differently than I've done now. And I hope that with a few of you are going to do that. And make a change in the community. Make a change in how you treat patients. Make promise to it. It's not going to be easy, but this is what I tell every addiction patient I see. I'm just not going to tell you it's going to be easy. I tell you it's going to be worth it. And it's going to be worth it.
Well, if you want to go next year, we just on the front end, not on the addiction side, but people that are just getting a post-operative prescription for opioids or something. What would be our doctors the party line to the doorknob thing that we call it when we use the prescription?
I think it's like I said earlier, it's use safe storage, safe disposal. Okay, simple messaging. Use them only as directed and only as long as you need to, and don't take any more than you need to. It's that kind of message on the use. Throw them out of not in the medicine cabinet, lock them away, and dispose of them when you're done. And become a harm reductionist. Have the naloxone. I'd add that as a fourth pillar. You do those things, people are at much lower risk. And you just really, really reduce everybody's risk of having a problem or sharing them or all those things. That's pretty easy to do. So use safe storage, safe disposal, naloxone.
If we have your personal story, be brave and share it. If it's you, a family member, or somebody's getting permission. I could just imagine I had this thought, like when you said, I was like, But the doctor said, hey, if you struggle, you can't get off. That's really what I did. Tell me that I might struggle. And if I'm struggling, if you are a safe person, for me to also come back to you. Because the one I couldn't go back to was the doctor was telling me. At all, never went back to me. So I'd like to be in a great relationship with you that says, hey, you tell me like if you struggle, I'll help you and I'll come back to you. I promise you I did that.
I think for our line of work, it's really helpful for obviously them to know there's somebody to go to, and not to be afraid to call us, right? BCMS and police and stuff, they're always scared. That new law that's put into place, I've probably been on 100 calls for overdoses, and they're always, oh gosh, am I gonna get arrested? Are they gonna get arrested? No, right? We're gonna take those pills. They're usually the N30s that I showed you, and we're gonna dispose of them, and nothing's gonna happen. Right? So just let them know if you're in trouble, not in trouble, but if you overdose or if somebody has an issue, get into it, whatever. We aren't going to charge you with anything, right? So good to make it off. So you can throw that in there if you want to.
So young people need to hear that because a lot of young people think they're going to, so they don't. And I did hear a story of they left their friend. So I think it's an important message, especially if you're dealing with young people, to tell them that they would get.
We all carry naloxone. Every single place up there has naloxone, and then our EMS gives it, right? But we're there first. We have.
Plan. If we can hear about how you're gonna do it tomorrow, including the naloxone, good Samaritan law and raising awareness. And the only other part I would add, we have wrap up session, is making people aware that all these stuff. Because even though you're giving them certain pill, say, and by the way, or any other stuff, just know that Boulder County and every community. And just raising awareness because we're having seen tragically or
Thanks so much. It's 9 o'clock, so we're gonna close it out. The website, it's a members only section of the links. Cecilia is going to assemble these things. There are takeaways, little 50s on the way out, including your own.